the history and the development of national health insurance in Indonesia, which I think has been an enormous step forward, but with complications. So it's an honor to us that you decided to make one of your, I know it's a short visit here, and that you decided to join us at Harvard, and welcome. Selamat datang.
So it is my honor that I'm invited to deliver a speech here on the Indonesia's new National Health Insurance Program, history, progress, ethical challenges, and implementation and practice. So, as mentioned by Prof. Byron, that I was involved in developing this health insurance or social health insurance, or we call it national health insurance, or now we call it universal health coverage. So those who do not know Indonesia, here Indonesia is member of ASEAN countries. So people usually know Bali rather than Indonesia. When I first time visited US, one of my colleagues asked me, so where are you from? I said from Indonesia. So where is Indonesia inside? What part of Bali Indonesia is? So there's a problem. And there is East Timor. So there are some countries in the ASEAN. As we know that actually Indonesia have the global commitment in shaping better world. For example, President of Republic of Indonesia together with Prime Minister of UK and President of Liberia as the co-chair at that time was assigned by United Nations to develop draft of post-MDGs agenda. So these three persons is quite busy that time, and then drafting there were 12 previously goals, and then by United Nations, then it was improved to be 17 goals. And Indonesia, as a member of Foreign Policy and Global Health Initiative country, that time also together with these countries to develop UN Universal Health Coverage Resolution draft. And I was lucky because I represented from Indonesia. And then this year, WHO, we're in the 70th anniversary in World Health Day 2018. The theme was chosen as universal health coverage. Everyone, everywhere. It means ensuring that everyone, everywhere can access essential quality health services without suffering financial hardship. And as we know that half of the world lack of access to essential health services, and each year 100 million people are being pushed into extreme poverty because they must pay for health expenses out of their own pockets. It was based on the report by WHO and World Bank in the year 2017. So then we know that to shape better world, there are global commitment to achieve sustainable development goals, at least in my opinion. Goal number 3 and number 4, good health and well-being and quality education. So here, if we would like to, produce quality of competitive human resources with integrity, at least not only providing high quality of education, but also in the globe providing access of high quality of healthcare with affordable costs to all citizens, we call it universal coverage, to get at least the target is 1 billion more people to benefit from universal coverage by the year 2023 if we are to meet the sustainable development goals by the year 2020. Therefore in Indonesia now we would like now in the process of higher education reform, where the university is not only agent of education, agent of research, but also as agent of cultural development, and also transferring knowledge, technology, and also agent of economic development. So now how to link between the university and also the industry. So the research should be linkage. So in Indonesia now, the way to measure the university is good or not based on the new main indicators of this one. So this is our strategic planning in 2015 to 2019. So now back to the healthcare reformation. So how is Indonesia, as you know, to know the figure compared to UK or US? GDP per capita, it is very far, we 3.9 per annum. UK is 42, USA 56. GDP on health, we are only 2.8%, or 27 billion US dollar, and UK 234, and US is huge number, 3,400 billion. Government for budget for health 5.4, 150, and then 980 billion. That spending. And then hospital per bed here, medical doctors, then nurse per 1K, 2, US, UK is around 9.5, 9.4, and you know the mortality rate here in the 1960, Indonesia is only 46, US 70 and UK 71, but then the development, now Indonesia already achieved 70 years in the 2014, 2015, and US 79. And if you look here, of course, US spent a lot of money here, and you can say that commitment of Indonesia is a little bit low because only allocated money 2.8% of the GDP. But if you look the result, see here is, you know, spending more than 10 times, but we get, you know, the life expectancy. Of course, it is different, but I think in the same, you know, opinion, it is more efficient also.
More than 100 times.
Yeah, 100 times.
Yeah.
100 times, not 10 times, 100 times.
But by the time you become over 70, you're glad that it's 79, not 70.
Oh, yes. Right, yeah. Okay. Yeah, here is the Indonesian figure. So I will not talk because it is too detailed. So then, what the Indonesian healthcare system trying to reform? So, you know, we already reformed healthcare financing reform and healthcare delivery system reform. So first, previously, for the healthcare, everything is managed and carried out by government. But now, after we establishing a health insurance carrier, national health insurance carrier, or we call it BPJS Kesehatan. So now the, you know, task was divided, task by the government, which is setting up regulation and then, you know, to control the quality and also handling health services in very remote areas. And for the curative services, it's mostly managed and done by BPJS Kesehatan. So this the comparison before and after reformation. So before reformation to universal health coverage, many poor and near poor in Indonesia have difficulty to have access to healthcare. And there was a pomeo in Indonesia and a book entitled "The Poor is Forbidden to Fall Sick." But now, when we already reform using universal health coverage scheme, now changes. The poor is, if they fall sick, is forbidden to pay. So, and now health is not important issue for public that time, around 10 years ago. If, you know, election, thing like that, it is not an issue. But now it's very important issue. Doctor, specialist, hospital, they can set their own tariff, very high tariff. But now the tariff is set by BPJS, but little bit too low. So doctors are little bit not satisfied, and also the hospitals, because little bit too low. And no structural referral system of healthcare. So now structured like here HMO, thing like that. Then not cost-effective healthcare system, here cost-effective healthcare system. So how is the situation of universal coverage in Indonesia a decade ago? So not long time ago. Population coverage is only 11%, mostly are government employees, civil servants. Financial protection, heavy out of pocket, 70%, and many people in rural areas, or my neighbor also, if they got sick, they can sell, their belongings like a cow or anything, house sometimes. And some, offered me, they thought that I have money, can you, buy my house because I have to pay the hospital. It was around 10 years ago. And poor, again, it was forbidden to see. This is the history actually of universal health coverage in Indonesia and the major milestone. So in 1969, it was first time civil servant benefit scheme was introduced, and we call it ASKES. Then early 1970s health cards, early 1990s managed care system was introduced, because at that time I was also sent to US, especially to UCLA, to study about managed care. So we started SMO, PPS, thing like that. And it was developed in Indonesia. Then 1992, Social Security for formal sector employees, jam sostek. After economic crisis, 1998, Social Safety Net Program for Health was implemented. And then that is the milestone. In October 19, 2004, Indonesia enacted the National Social Security System law. But the problem is, long time they cannot be implemented. But in the year 2005, the health insurance for the poor offered 76.4 million program at million people, and the program was introduced. And I was asked by the minister, that time minister from alumni from Gajah Mada, as the consultant, how to develop this. And local government health insurance initiative grew at that time, and centralized. We are still confused at that time to choose what type of system. Centralized, each state like Medicaid here, or centralized. So then, centralized versus decentralized, but not really decentralized, but integrated decentralized health insurance system. And then we went to the Constitutional Court. In 2008, implementing prospective provider payment system, INA DRG and capitation. The DRG was first time developed in US, especially in Yale University. In 2010, we have jumper sub health insurance for the delivery. So every pregnant woman who delivered, it was covered and paid by the government. So some rural area, they are very happy, so they just pregnant because it was paid by the government. Then 2011, Act on Health Insurance Carrier. We have actually, like in US, many health plan, many health insurance. But in this year, all the health insurance carrier should merge to be one. That is maybe BPJS. Actually, two BPJS for employees and BPJS for health. And the real implementation in the year 2014, and comprehensive coverage was introduced. So now we would like to see one by one. First, the government, and then health insurance members, BPJS Kesehatan or health insurance carrier, and health facilities. The government has the responsibility to complete and renew necessary regulation. And within 1 year that time, we were assigned to finish all these regulations, and not easy. Conducting monitoring evaluation, establishing health technology assessment, whether new drug should be listed in the formulary or not. Then adding health infrastructures, preparing and producing human resources for health, improving data for the poor. It is not easy to differentiate which is the poor, which is almost poor, which is almost rich. It's not easy. allocating necessary budget for the poor. So then we make roadmap that in the year 2019, all Indonesians should be covered. So now number 2, the membership, expanding of the membership. Again, the whole population should be covered in the year 2019. And now we reach 196 million people was covered, so it is around 77%. And we established like care centers to see the satisfaction level. For example, waiting time should be less than 30 minutes service compared to non-member, what about the co-payment, and so on and so forth. So as we know in WHO, there are 3 types of indicator of universal health coverage achievement. So we call it the breadth, who is insured, and also the depth, which benefits are covered, and the proportion of the cost is covered.